Hi, everybody. I'm Lynn Hernandez with the Desmoid Tumor Research Foundation. It's great to be here with you today for our webinar about fertility considerations for desmoid tumor patients. Before we get started, we'd like to acknowledge and thank our event sponsor, SpringWorks Therapeutics, for their support and commitment to patient education. We invite the community to pose fertility questions in the Q&A. You'll see the Q&A function at the bottom of your screen. And the chat function will not be monitored for questions during this session. Our attendees are welcome to share their experiences there. Those will be public. By the way, thank you to everyone who submitted questions to us during registration. Our focus today will be fertility. We do have resources on our website about pregnancy, and I'll be sharing them in the chat for you during our webinar. Please stay tuned. If you know someone who meant to join but wasn't able to, please tell them that this recording will live on our website and will notify the community when it's public. Please be sure to subscribe to our newsletter at dtrf.org for notifications. This webinar is going to be 30 minutes, so that's just for your information. Our guest today is Dr. Laurie McKenzie. She is a fertility specialist at MD Anderson Cancer Center. She teaches for and is a board examiner for the American College of Obstetricians and Gynecologists. Dr. McKenzie's primary research interest is assessing the ovarian toxicity of cancer therapeutics. Her practice at MD Anderson encompasses fertility counseling and preservation prior to cancer treatment, as well as family building services for both men and women. Dr. McKenzie, we're so grateful to have you with us. Welcome, and I'll turn it over to you.
Hello, everyone. Thank you for taking the time to join us during your lunch hour. As Lynn mentioned, my name is Laurie McKenzie, and really fertility preservation is a passion of mine. And I really wanted to focus today's talk just to define a little bit more regarding what is the field of oncofertility, what is the rationale for this, especially in the context of desmoid tumors, and to discuss with all of you what would recommendations be in terms of obtaining a baseline assessment of fertility prior to treatment, and how do we assess and track fertility after treatment. I will cover broadly what are fertility preservation options that currently exist, and specifically discuss some of the reproductive considerations with nirogacestat and some clinical considerations. So I'm going to dive in. We will keep this fairly brief in terms of slides, because I really would like to open this up to questions and concerns for you in the audience. So first, let's start with what is oncofertility. This is the bridge between oncology and reproductive medicine to expand the reproductive options for those either affected by cancer or about to undergo cancer type therapeutics. If we think of desmoid tumors specifically, keeping in mind the peak incidence of these tumors are for patients of reproductive age, ages 30 to 40 years, although certainly can affect all ages. And more commonly, we see impact in terms of women with roughly a 2-to-1 female to male ratio. So when we're talking about what is the impact that therapy can have in terms of reproduction, there's multiple factors, multiple variables that we consider. The first is, what is the age of the patient? So if someone is getting ready to start treatment, what is that individual's age? What are the type of agents or treatment options that are proposed? The dose of these agents, the number of treatment cycles, and very importantly, what is the baseline fertility status of someone that's about to embark on therapy? So certainly if you have someone going into treatment that has very good ovarian or sperm function, they will typically recover fertility much better compared to somebody that maybe has compromised fertility going into treatment. And so objectively, how we assess reproductive function for women We discuss certainly the age impact, what is their reproductive history and menstrual status, and we make an assessment of what's called ovarian reserve. And ovarian reserve is the capacity of the ovary to provide eggs that are capable of fertilization that would ultimately result in a healthy and successful pregnancy. And there's several different metrics that we can use to assess a woman's ovarian reserve. FSH, estradiol, even inhibin has been used. But the two most common factors are AMH, anti-Müllerian hormone, which is a blood test, and an antral follicle count. An antral follicle count is where you do an ultrasound of the ovaries. This is typically a vaginal ultrasound, but can also be done abdominally, where you look at the ovaries and you actually count the resting number of follicles that you see. And so we use these two metrics, the AMH and the antral follicle count, to determine what is somebody's ovarian reserve, what is their baseline fertility. So we have something objective that we can measure as somebody has completed treatment and is in their survivorship care. And then also these two parameters can help give us some prediction in terms of how well would somebody respond if they decided to undergo egg freezing or IVF. So very useful tests, and I usually have a very low threshold to recommend getting these checked prior to treatment. For men, the semen analysis is going to be the most important test of male fertility, and certainly his reproductive history. Was he able to lead to a pregnancy in the past? Has there been any prior gonadal surgery, gonadal trauma? But with the semen analysis, there's several parameters that we look at. We look at what is the total semen volume, what is the sperm count, what is the motility of the sperm, how is the sperm swimming, and then the morphology of the sperm. What is the size and the shape of the sperm? And this is a much more involved assessment, looking at the head, the midpiece, the tail of the sperm in terms of its assessment. And so when we talk about fertility preservation options, and there are several, gamete cryopreservation is what's utilized most commonly. And this is the process of preserving reproductive tissue to increase the likelihood of being able to have biological children in the future. And this is not a new concept. Cryopreserved sperm has been utilized to result in a pregnancy even back to 1953. The first child that was delivered from cryopreserved or frozen embryos was in 1984. The first child delivered via frozen eggs was in 1986. And in 2004, we saw the first child delivered via cryopreserved ovarian tissue, where an ovary was removed, ovarian strips were then cryopreserved, and then that tissue was reimplanted back into the individual. And so when we have someone that's considering cryopreserving eggs, that process takes about 2 to 3 weeks. And that's really important to know. If somebody is about to start treatment, you need to have this 2 to 3 week window to allow for egg freezing if this is something that is important to the individual. And why it takes about 2 to 3 weeks to do this is because, remember, a woman typically produces only one mature egg each month. And the goal with egg freezing or embryo banking is to try to recruit multiple eggs during that 1 month period of time. And so how that's achieved is by administering recombinant hormones. So these are the same hormones that a woman produces, FSH and LH, but just in a much higher dose to try to get multiple eggs to respond. And these are sub-Q injections that someone self-administers for approximately 8 to 12 days, but sometimes can take a little longer, even up to about 14 or 15 days. And so this is what we would be expecting on ultrasound. This is a human ovary, and these are resting follicles that you can see along the perimeter of the ovary. And see how they're nice and small. These follicles each contain a developing egg. And then in response to the fertility medications, these follicles should grow. And then the size of these follicles correlates to when that egg is mature or ready for harvest. And so typically we like to see this mean diameter about 15 to 21 millimeters. That tells us that the egg should be mature. And then we induce the final maturation of those eggs with a what we call a trigger injection. And then 36 hours later, the eggs are harvested. And this process is done vaginally. It takes about 20 to 30 minutes to harvest the eggs. And this is done under ultrasound guidance. So we use a vaginal ultrasound with a long, thin needle attached to it. And then we see via ultrasound where each of these follicles are. And then we go into each of these follicles, aspirate that fluid, and then identify the egg inside each of those follicles. And so when we look at different assessments in terms of fertility, and we're thinking of cryopreserving sperm, for example, and we'll go into a little more detail with this, this needs to be done prior to initiation of any therapy. And so the sperm can remain just like oocytes and embryos cryopreserved indefinitely. Even sperm that's been cryopreserved over 20 to 30 years has still been shown to be viable. And so when a semen sample is submitted for cryopreservation, that sample will be subdivided into multiple smaller aliquots or vials of sperm. So hopefully there would be multiple tries for pregnancy from that one collection. And what's really important is to get a copy of that report. If somebody elects sperm cryopreservation, this is true for egg cryopreservation or embryo cryopreservation, you always want to get a copy of the report because you want to see how many eggs, how many vials of sperm have been cryopreserved, and keep that record in a safe place. I usually say keep this where you keep your Social Security cards or birth certificates, because years can go by before somebody wants to utilize these samples, and sometimes patients can forget where were these samples stored. Specifically with the sperm, we like to see at least 5 million swimming sperm per vial. And if that's the case, then that vial can be used for either insemination, kind of the turkey baster method, or for IVF if needed, if the counts are exceedingly low. And if there are very few vials of sperm that are cryopreserved, it may be worthwhile to submit a second or even a third collection. Once sperm is harvested, that sperm could then be used, and this is for couples or individuals that are considering embryo banking. That sperm can be used to fertilize the eggs, and this can be done in two ways. One is via conventional fertilization, where you just put the sperm with the oocytes at a set concentration. The sperm will then fertilize the eggs on their own. The other option, if somebody is cryopreserving embryos, is to microinject each individual sperm into the egg. And this is a video just showing that technique because I have a lot of questions, often from individuals asking about what is ICSI. And here you can see a human egg right here. And if in this little pipette, you see this small entity right here, and that is the sperm that is then being suctioned back into the injection pipette, and then you'll see it re-injected into the oocyte. So you can see what the size difference is. This is a human egg versus a human sperm, and that's why it's taken much longer for fertility clinics to figure out how to cryopreserve eggs versus sperm. If you notice, there was significant lag in time in terms of when oocytes were able to be successfully cryopreserved and thawed compared to sperm. And it's primarily just because of the size differential, much larger surface area for the egg. And so these are the two methods that are used for fertilizing eggs if somebody is interested in either going through IVF, in vitro fertilization, or banking embryos as opposed to just oocytes. If somebody undergoes embryo banking or IVF, once the eggs are fertilized, they're tracked in terms of their growth rates, and there is a very specific growth rate an embryo should go through. Typically, by day 3 in culture, it should be about 8 cells, and by day 5 in culture, it's usually several hundred cells, resulting in what's called a blastocyst, and this is a picture of a representative human blastocyst, just multiple cells This clump of cells right here are the cells that lead to the actual embryo itself, and then the cells that surround the periphery of the embryo are the placental cell line or trophoectoderm. And this is the stage of an embryo that we typically recommend for transfer, a day 5 embryo, although embryos can be transferred anywhere from day 2 to day 7, but the highest success rates are typically associated with a day 5 or day 6 embryo. Pre-implantation genetic testing can be performed on embryos, and this is where you can test for abnormalities in chromosome number or for inherited genes that may put somebody at increased risk for developing desmoid tumors or other entities. And how this is performed is by biopsying the embryo. This is typically biopsied around day 5 or 6. This is showing a laser site with the embryo that's creating about a 20 micron perforation around the shell of the embryo. And it allows some of the cells from the placental cell line to then herniate from the embryo. And then those cells are then biopsied and submitted for analysis. It usually takes about 2 weeks to get the results of these cells back. And then that way, is that embryo genetically competent and what the genetic makeup is of that specific embryo. ASCO, the American Society for Clinical Oncology, has really done a great job in terms of advocating that healthcare providers should talk about fertility preservation for patients before they start any type of therapies that may impact fertility, and that this discussion should be obviously before treatment starts so that they have the full spectrum of options in terms of banking sperm, eggs, or embryos, and at least to have an understanding of how could their fertility be impacted by therapy. A recent guideline that just came out in the fall of 2023 has also advocated assessing ovarian toxicity. So if you have women that are going through cancer therapies, making sure that they've had a baseline fertility assessment and that 12 to 24 months after they're finished with treatment, these same ovarian reserve markers should be checked and tracked to see how do these therapies affect fertility. And ASCO does emphasize that this issue regarding future family building is of such importance to our patients that it cannot continue to be overlooked because we have not always done such a good job in terms of counseling patients. And then if we look at nirogacestat specifically, this is a drug that I'm sure many of you are familiar with that received approval right around Thanksgiving of 2023. And there's very limited reproductive data currently in humans regarding this drug. And if you read the FDA guidelines, they state very clearly that female reproductive function may be impaired in patients, and the impact on fertility may depend on factors including how long someone is on therapy and what the state of gonadal function is at time of treatment. So they too appropriately, recommend advising patients on the potential risk for ovarian toxicity before starting treatment and to use effective contraception during treatment and for 1 week after the final dose. And the half-life is quite short with this drug. It is out of your system very quickly. But again, that 1 week washout is quite important for individuals that are considering nursing, for example, or conception, and if they need to be using reliable contraception. So some important considerations and what would be helpful to discuss with your clinical team if you are considering starting nirogacestat or even other therapies. What is the anticipated duration of therapy? How will my reproductive status be assessed and how will it be tracked? And what are appropriate options for me in terms of undergoing fertility preservation? Is there anything that I should be thinking of or doing from a fertility preservation standpoint? Because when someone has already started treatment, then these options are contraindicated. And what I'm referring to is any systemic therapy, for example. And what are financial resources? What do we have available in terms of covering the cost of some of these fertility preservation techniques? And a lot of unanswered questions that we have are, what is the impact of pregnancy itself? And I think Lynn had mentioned, sharing some resources. But again, this is such an individualized discussion and so important to have really on a one-on-one basis with your oncologist and sometimes in conjunction with a maternal fetal medicine specialist if someone is contemplating pregnancy. So with that, I would like to open it up for questions, comments. Would just really appreciate anything anyone that's joined us is willing to share.
Okay, so we have one question. What are the effects of hormonal stimulation during IVF on a desmoid tumor? Can you speak to that?
I can, and I'm so glad that question was brought up. So thank you for whoever submitted that. I tend to be much more conservative in terms of exposing someone to elevated estrogen levels during, in general, but especially during fertility preservation. So remember that slide where I was showing you for that week and a half or so, you are taking fertility injections. Well, those medications can markedly increase your estrogen level. And I really would like to avoid that as much as possible in someone with a history of desmoid tumors or a current desmoid tumor. And there's actually a medication that you can use called letrozole or Femara. And it's an aromatase inhibitor that keeps the estrogen levels low while you're on those fertility injections. And so that is my standard of care recommendation for anyone that is considering egg freezing or embryo banking. But your fertility specialist, who may not be as familiar with desmoid tumors, may not know this. And so I think it would be something that I would be very proactive about bringing up to your fertility specialist or reproductive endocrinologist if you're considering egg freezing or embryo banking, just saying, hey, I would really like to use this medication to keep the estrogen levels low during my stimulation. So it was a great question. Thank you for bringing it up.
Another question. What would fertility preservation look like for a 15-year-old that has a desmoid tumor versus someone in their 20s?
So obviously we would be a little more sensitive if someone has not been sexually active, for example, how we're tracking the response to the fertility medications. And so in that patient population, we would prefer to do abdominal ultrasounds to track how the ovaries are responding to the fertility medications as opposed to vaginal ultrasounds. But as long as someone is post-pubertal, so as long as someone has already started their menstrual periods, they can still undergo egg freezing or embryo banking. The problem is if they haven't started puberty yet, the only fertility preservation option for them would be ovarian tissue cryopreservation, where you would then remove an ovary and cryopreserve that ovary. And for most women with desmoid tumors, we wouldn't recommend removing an ovary if we could avoid it, simply because, for example, depending on what type of therapy they're receiving, the hope is that for the vast majority of these patients, their fertility would recover post-treatment completion.
Okay, let's get you another one. What is the major fertility impact of some of these desmoid medications to male patients? And are these impacts reversible after stopping the medications?
Yeah, and that's an ongoing area of study because we have such limited data. The primary data that we have is just strictly in animal models that could suggest some impairment of spermatogenesis on patients, for example, that are on nirogacestat. So I have a very low threshold to recommend sperm banking for these patients before they start treatment. And really, the hope is that this would simply be as a backup, kind of as a plan B in the event that their fertility was compromised by treatment. Now I can say For the patients that I've been tracking personally, and again, this is not me speaking as on behalf of SpringWorks, but I can say of the patients that I've been following, for both men and women, I have seen good recovery of fertility after some of these gamma secretase inhibitors. But the follow-up period is short. These drugs have fairly recently been utilized, and so I don't have long-term reproductive outcomes that I can report. Mhm.
Okay, thank you. I'm seeing a number of questions coming through that are on pregnancy, and I just want to direct you guys to the chat. I'm seeing a lot of those, so maybe it would be helpful for us to bring on someone to specifically talk about pregnancy. Maybe that's a topic we should be focusing on, which is great information. So I would just direct you guys to the chat, see if there are any videos there, because there are some questions, research articles, and videos on pregnancy. And so, Laurie, Dr. McKenzie, I have another question for you. At what stage in treatment would you consider preservation? Would it only be before systemic therapies? And if so, could you point to specific ones?
Yeah, so typically I would recommend before any type of systemic therapy to think about, and have this discussion with who's managing your therapy. Would egg freezing, sperm banking be something that's recommended? To me, getting a baseline fertility assessment, whether it's a semen analysis or an ovarian reserve assessment, I would consider that a no-brainer, so to speak. I would certainly want to get a baseline fertility assessment. But once systemic therapy has started, then that would be contraindicated in terms of proceeding with sperm banking at that time. And you would need a washout period depending on what drug you're utilizing.
Okay, great. And I have one other question for you. Is there a, and I think that you've touched on this, so it might be a little bit repetitive, but is there a difference in fertility issues between sorafenib versus GSIs? And is this important to keep in mind with the age of the patient?
Yeah, I think again, just having a low threshold in terms of the fertility treatment, and we don't have enough data in humans over a long period of time for us to have meaningful conclusions. I mean, my hope is 10 years from now, we will have another webinar that says, you know what, we have full restoration of fertility after these medications, that we really don't need to think too strongly about fertility preservation, depending on what the age of the patient, the duration of therapy. But right now, I tend to be much more conservative just because we don't have that data. And there has been enough, at least information in the animal models to say that, yes, there is some compromise from a reproductive standpoint. So for so many, future family building is so important. And so we really don't want to limit options that patients have with their own gametes. And keeping in mind, there are many options and many paths to childbearing. But there are many patients that it's really important to them to be able to conceive with their own sperm or their own oocytes. And so I typically have a pretty low threshold to recommend this, especially in light of such limited data that we have currently.
Thank you so, so much, Dr. McKenzie. I know your plate is very, very full today. We really, really appreciate your taking the time. I'm actually going to let you go now because I know you have another call you're hopping on, and
Yes,
then I have a
yes,
couple of things for the community. So thank you so much for your time.
of
Thank you.
course. And thanks so much for being such an advocate, Lynn. It's just wonderful, to have this information out there, and I appreciate the opportunity to speak with you today. So have a great
Absolutely.
day.
All right,
Bye bye.
take good care, Dr. McKenzie. Okay, so everyone, please note that each desmoid tumor case is different. These conversations are not intended as medical advice for any individual problem or as a diagnosis, treatment plan, or recommendation for a particular course of action, and should not be used as a substitute for professional medical advice and services. Thank you again to our event sponsor, SpringWorks Therapeutics, for their support and commitment to patient education. Just a reminder that this broadcast will be accessible in our video library on our website. If you go to dtrf.org, look in your upper right-hand corner, you'll see video library. We have a wealth of information there. And if you subscribe to our newsletter, we'll make sure that we'll notify you as soon as it's posted to the site. So please feel free to share with other patients, caregivers, etc. And we'd like to thank you for being with us this afternoon. Again, it will be at the video library. Please email us with any questions at info@dtrf.org and have a wonderful afternoon. Take good care. Bye-bye.